There are studies that were kind of presented a few years ago, but more importantly, recently, some data from the Hermes cohort of all the big thrombectomy trials has shown that there is signal or benefit for these patients with lower aspects. The majority of the patients in those studies had high aspect scores, so you try to design studies to show a positive effect, so the inclusion criteria is fairly narrow. What we've seen more recently with the Dawn and Diffuse 3 trials is that the time window has been expanded to include more patients. I think what we're going to see with the next round of studies, based upon some of the data published recently from the Hermes cohort, is that there will be patients that can benefit even with larger core infarcts. Absolutely. I think we have one of the most powerful treatments, if not the most powerful treatment in medicine available to us, patients with large vessel occlusion performing thrombectomy. So, in my opinion, it's almost unethical not to treat as many patients as you can. So I think that the criteria needs to be broadened because there are patients out there that can benefit significantly in return to independence if we perform a thrombectomy. There are downsides. If you have a large stroke, you have a higher risk of having a reperfusion hemorrhage or conversion of a stroke to a hemorrhagic stroke where the patient won't do well. If you have a large vessel occlusion stroke and you don't open up the artery, they're unlikely to do well in and by that self. I think there are other risks. You can have malignant edema. I think the other risk is that you're performing a procedure that may not benefit the patient, so it's called futility. So if you're doing this, a lot of resources, a lot of cost to healthcare, and the patient may not benefit. So I think the margin is still beneficial. We have to prove that. But the downside is really hemorrhage or the patient not getting better. I think the goal is to prove that low aspects core infarct patients will benefit from thrombectomy. And we might find that you need an aspect score of 5, 4, 3, or 2 to show benefit, maybe not 0 or 1. 0 is really a completed stroke in that middle cerebral artery territory. But I think what it's going to do is show benefit in patient population, and we're going to start treating those patients. So I think we have a number needed to treat of this of 2 for LVO, and that's compared to 20 for PCI, for STEMI, or for acute MI. So we have a therapy that's really effective, and we need to expand this indication to more patients to get them treated and hopefully back to independence. We need to think about treating every patient we see. And we have to have an extremely good reason not to offer that patient this therapy. Every one of us, including me and my partners, we treat about 300 patients a year. We see patients and have seen patients for the last several years that present with low core infarcts, large core infarcts or low aspect scores, and we perform the thrombectomy not really thinking that they're going to get better, and we are surprised more often than not that these patients have significant improvement and go home for independence. So I think if you can find one patient that you can save where you're not really sure, that means that there are a lot of patients out there that aren't being treated, because a lot of centers are very restrictive on their inclusion, which to me means there are thousands, tens of thousands, millions of patients out there that could benefit that right now are not being treated, and that's a shame.